Okay, so infection affecting total shoulder replacement. I want to acknowledge Andreas Leonido and George Panagopoulos, my fellows that collected this data for me. My disclosure. So infection rate is approximately 1%, is higher in revision surgery, higher in reverse arthroplasty, and probably much higher with a stealth infection with the P. acnes, that now it's called C. acnes, to confuse us even more, but with this low-grade infection. Now, the microbiology, with Staph aureus or Staph epidermidis, you get classic signs of infection with C. acnes, which are the 50% to 70% of the common pathogen in infected joint replacement. It's a low-grade infection. There's no clinical signs of infection. The serum ESR and CRP are usually normal, and it's difficult to grow in culture, so you need to grow it for at least 14 to 21 days. And even in histology, it doesn't show 5 polymorphonuclears per high power field, but it shows more lymphocytosis. So it's a different bug. And this is our famous study that we did many years ago, and where we found about 42% of P. acnes in the joint in virgin shoulders with arthritis coming for shoulder replacement. And the question is whether we underestimate this bug in the etiology or pathogenesis of osteoarthritis, and maybe this bug is the cause for late postoperative post-arthroplasty, all these cases that that don't seem to be infected, but they are painful, there's some loosening, aseptic so-called loosening, whether they're all infections with low-grade infections with this P. acnes. And indeed, if we look at the literature, we actually did this study with 55 patients, and as I said, almost 42%, 41.8% were positive without any signs of infection. And our definition was very strict. We had to take at least 5 specimens, and if more than 50% of them were positive, we regarded it as positive. If it was only 1 or 2 specimens positive, we didn't regard it as positive. So I believe that the rate is even higher. Histology, again, as I said, what the histology showed more lymphocytosis and plasma cells, and all the classic 5 polymorphonuclears per high power field. And if we look at the literature, this study from Topolsky, that in a revision of shoulder arthroplasty with positive intraoperative cultures, they actually found more than 60% of the shoulders undergoing revision for sort of aseptic loosening. They were positive cultures for P. acnes. And again, this YP Levy, again, he found 56.3%, again, with P. acnes, again, for aseptic so-called loosening. And again, this paper from Pottinger, again, about 56%, again, and 70% of these that were with bug were P. acnes. So I know that we can see that J.P. Warner suggested to do an arthroscopy to take specimens, and indeed, again, he found in his arthroscopy, again, 41.2% of these patients with aseptic loosening were positive for C. acnes. So it is unrecognized low-grade infection that probably, what I think, that's my theory, that it's an unrecognized low-grade infection at the time of the primary joint replacement, and that it may be responsible for this painful joint replacement and stiffness and aseptic loosening in inverted commas. And that couple types of infection. So you have the acute early post-op, and there's acute late, the hematogenous infection, and there's called the low-grade infection. And I think the acute is early versus late, it's about 6 weeks. Actually, clinical suspicion, you have to suspect infection in all these cases of painful shoulder replacement, stiff shoulder replacement, or if you have signs of infection. So you have a chronic pain, stiffness, early loosening, osteolysis, high index of suspicion for infection with a C. acnes. You can have obvious signs of infection. You can have the redness, swelling, draining sinus, pus, temperature, and the markers are high, but you can have all of them normal. So with microbiological diagnosis, the CRP is negative in 75% of the cases. ESR is negative in 86. Synovial interleukin 6, again, questionable. Alpha defensin, questionable, especially for P. acnes. Aspiration, again, it will be positive between 39 and 56% only. Sonification, Carlos Torrens showed that this doesn't show much improvement in identifying the bug. And PCR, again, it's in his infancy at this stage. Doesn't really work well for P. acnes. And obviously, we have to have extended cultures. Always think about P. acnes. I will keep calling it P. acnes. It's easier for me. Again, I said alpha defensin is not really great for P. acnes. And the options for treatment are arthroscopic debridement and washout with keeping the implants. So debridement, washout, and exchange of the modular parts. Single-stage revision, two-stage revision, permanent spacer, resection arthroplasty, arthrodesis, or antibiotic suppression for the rest of the life without an operation, again, in patients that are not fit for even a haircut. And again, this DARE procedure, arthroscopic debridement washout for acute early infections, ideally less than 3 weeks of the onset of the infection. The earlier, the better the results are. Best for implants that have less or no modular parts, so less modular parts are better, less sanctuaries for the bug. You may repeat it if appropriate, and you need to have an antibiotic regime that have at least, is pathogen specific, but you have at least 2 drugs. One of them should be rifampicin, because that breaks the microfilm of the bug. So you either clindamycin and rifampicin, or amoxicillin and rifampicin at least for 4 weeks. And this is a case that I did 17 years ago. She developed early infection, and with this resurfacing, I did a washout, and she's 17 years, yes, she's got erosion of the glenoid, but she's still functioning, and she developed a hematogenous infection after a teeth treatment by the dentist. Again, so early infection, you can do, again, what you do, exchange of a washout and all that, but an exchange of the moving parts. So if you talk about reverse, the glenosphere and the liner. And what I use in recent years, I use this stimulant, which is the implantable antibiotic loaded biodegradable beads. They're made of calcium sulfate with antibiotics, and you could put the proper antibiotic for the bug inside them. If I don't know what the bug is, I will treat it as P. acnes, and I'll put the antibiotic inside, and antibiotic regime for 4 weeks at least. You can see that you can put these beads both around in all the tissues, and they will actually resorb within a few weeks. So this is this gentleman, and you can retain the implant in 70% of the cases. If you did it early enough, you get good function, and you need to get some suppression with antibiotics, and sometimes it's longer, and the earlier the surgery, the better. If you do a single-stage revision, you have to stop antibiotics 2 weeks before surgery to take multiple micro specimens with all antibiotics that until the specimens is collected. There's no point of giving antibiotics and then taking the specimens, because you won't be able to grow the P. acnes. Removal of all the implants, including all cement and everything, meticulous debridement and washout. It's like a tumor surgery. You have to remove everything. Reinsertion of the new prosthesis, and use these stimulant beads, and again with antibiotic regime. The nice thing about these beads that you can actually put them inside the bone and around the tissues all over. So this is an example. This gentleman had this stemmed total shoulder replacement, was quite happy with that, and then he developed an infection in his toe, and this jumped into the shoulder. This was a colleague of mine that asked me if I can take over this guy. You can see he's got a sinus. So I actually took over, and I was lucky enough, because this is a very difficult implant to remove. I was lucky enough that it was infected, and I could remove it in one piece. And good debridement, washout, and then I use these beads and I put it both into the bone and around the soft tissues. And this guy was lucky because I could preserve the proximal bone and remove the whole thing in one go, and I managed to revise him to a stemless reverse shoulder with the beads. That's how it looks the day of surgery with all the beads around. This is this gentleman a year down the line. He's got good function, no infection. You can see that all the bone was incorporated around the implant. So I moved him from a stemmed implant to a stemless implant with good bone. You can see that all the shaft is filled with bone. That's another patient that came from Canada with this resurfacing that was stiff and painful. I suspected low-grade infection, and I did a revision to a verso, a stemless reverse with the beads. And this is a year down the line. And this is a Skype consultation from Canada, and his function a year down the line. No signs of infection and good function. So it's a one-stage revision. So overall, as I said, did I go backwards? No. Yeah. Single-stage revision, stopping it 2 weeks before, and good clinical outcome. And it thought to be inferior to two-stage in the past, but now there's good eradication of rates, more than 90%, less surgery, better organism. Better if the organism is known is better, but if you don't know and you have to suspect P. acnes, if there's a fistula, it's not a contraindication for one stage, and there's less studies published on that, but can be a problem if you need to use a bone graft. And if you need to use a bone graft, you may have to do a two-stage procedure. And as you can see, this meta-analysis shows good rate of success in one stage. A two-stage, the first stage, you remove everything, clean everything, put an antibiotic-loaded spacer, a cement spacer, and use this antibiotic beads as well. And second stage, 6 to 12 weeks later, you repeat all the stages of stage 1, clean everything, remove everything, and if you're happy with that, put and you insert a new prosthesis with all these biodegradable beads with antibiotics. And if the organism is not known, unless it's P. acnes, unless you suspect P. acnes, you better do a two-stage procedure, as we said. So this is a case that this lady was a revision from from a resurfacing. She was infected straight away, and we tried to do a DARE procedure. We failed, and then we did a two-stage procedure. As you can see, put a spacer, and this is the second stage where we revised it to a stemmed reverse, and this is 2 years after the second revision, again, healed nicely. Again, in the literature, in the same meta-analysis, the success rate of double stage, a two-stage, is lower than single stage. And I think the more operation you do on these soft tissues, the lesser the good results you get. And this is some studies that shows, again, a 26% recurrence rate in two-stage, and the systematic review that shows that no significant difference between a single stage or two-stage procedure. Permanent spacer, I mean, some of them, as Ed alluded to that before, you have to leave them. Some patients tell, leave me, I'm fine, and you leave the spacer there. And there are cases that you have to do resection arthroplasty, like this gentleman here that had this horrible infection. It took me about 10 operations and about 2 years to get rid of the infection. And he wanted me to put a reverse shoulder there, and eventually I chickened out, and I said, no, there's a limit to what I can do. So he stays with that, and that's it. At least he doesn't have any infection, he doesn't have any pain. To conclude, you have to tailor the treatment to the patient. You have to keep high index of suspicion for infection. Be aggressive with acute infection. Act fast. That's the best chances for this patient. Stop antibiotics for 2 weeks before surgery. Withhold antibiotics until you took the specimen, and take multiple microspecimens, at least 5. Meticulous debridement and washout. As I said, tumor surgery. Better if the causative bacteria is known, but if not, suspect P. acnes and consider the use of these implantable beads with antibiotics, and the best is prevention. Thank you very much.